So I'm going to talk today about genetic aortopathies and where we've been and where we're going. Here's a list of genes that we've identified to date that cause heritable thoracic aortic disease. And at the top is FBN1, which causes Marfan syndrome. So we know a lot about the clinical phenotype of Marfan syndrome, but what about the rest of the genes? And with the initial publication, we got some information that as you go from gene to gene, there's variable phenotype associated with different genes. But in addition, even within a gene, there can be variation with different pathogenic variants. And this is just an example of this. This is Loeys-Dietz syndrome due to TGFBR2 mutations. And at one end of the spectrum, you get these children that are very dysmorphic and have other congenital birth defects and have very early onset aggressive aortic disease. And then you can have patients that look like they have classic Marfan syndrome, and the only way you can tell them apart is by genetic testing. But then there's a lot of people that look completely normal and don't have any syndromic features that have TGFBR2, and they tend to have the later onset disease. So, and then if you switch around and look at ACTA2, another HTAD mutation, this is a gene that really doesn't cause much in the way of facial dysmorphology, and it causes aortic disease, but some variants in the gene also cause other arterial disease. And unlike Loeys-Dietz, where the other arterial disease is aneurysms and dissections, in ACTA2, it is it's blockage of the artery. They go on to have Moyamoya disease and a blockage of the large arteries in their brain. And they can also go on to have with other variants, have very early onset atherosclerosis with coronary events starting in their 30s with no risk factors. So here we have two genes, both of them cause thoracic aortic disease, one's syndromic, one's not. One causes aneurysms and dissections of other arteries, and one causes a completely different vascular profile with Moyamoya disease and atherosclerosis. So based on just those initial reports with the gene, myself and others launched the Montalcino Aortic Consortium. I'm sure it must have been mentioned once or twice previously, and Arturo has been a member of this since the very beginning. And we wanted to efficiently and effectively collect clinical data on every patient worldwide with mutations in an HTAD gene. Initially, we've excluded FBN1 because we knew so much about it, but more recently, we just within the last year or two, we've added FBN1 back in because we really need to be able to explain the data, to compare the data we have for other genes with the data from Marfan syndrome. So, and so I'm going to go through some of the data that's already published from MAC, go through some data that's coming out soon, and then just briefly discuss where we want to go with MAC. So we started to look carefully and compare the first, we published individual papers on MAC data with many of these genes highlighted in red. But then we recently did a study comparing the individual genes. And what we looked at was the age of onset of an aortic event, which we defined as going in and repairing an enlarged aorta or presenting with a type A or type B dissection. And if you look at genes that and we sort of broke them down based on the genes here, like ACTA2 that disrupt smooth muscle contraction, and then the genes that cause Loeys-Dietz syndrome, which are the individual genes in the TGF-beta pathway. And so if you compare smooth muscle cells to TGF-beta or LDS genes and look at the age of onset here and the risk for an event, the age of onset of an event, you can see there's not much difference between the genes. So smooth muscle genes can be as early onset as TGF-beta genes. Now, if we go into the TGF-beta genes and look more carefully at the individual genes, you can see that there are differences, significant difference in the age of onset based on the individual genes. So right now we're grouping all these together, and right, I think we need to make sure that we know the underlying gene in an individual patient. And that's because, like, if you look here with TGFBR1 and 2, you have childhood onset events. With SMAD3, the disease in the blue line, the disease is much later onset. And if you look at that more carefully with TGFBR2, the average 50% of the people have disease by the age of 40. But at the age of 40, only 15% of the individuals have had an event in our SMAD3 carrier group. So there's a big difference based on the individual gene in terms of the childhood risk and the age of onset of disease. And then even if we take one gene like the TGFBR2, we can look at individual variants in that gene. And I already showed you a picture that there is a wide range of variation. So we asked the question, if you went from recurrent variant to variant, could you actually pull out variants that are earlier onset and ones that later onset? So, and for these studies, we only took groups of 10 or more patients. So we had enough numbers to really start looking at the age, rigorously looking at the age of onset. You can see right away this arginine 258 variants lead to childhood onset disease. So you know that if you have a child with this variant, you've got to be aggressive in the management. Whereas arginine 460 has much later onset and even begins to look a little bit like the overall SMAD3 outcomes with only 50% of 50% of the patients having an event by the age of 60. So, so this would argue that we need to know the individual gene for Loeys-Dietz, and even what variant in the gene will inform, to some extent, how to manage these patients. But if you look here, this is all the variants where we don't have a group of 10 patients to define the onset, and there's still a lot of those variants that lead to childhood onset. So we need more patients, more numbers to really be as precise as we can in terms of the variant-based management. And this is to also remind you that these patients do have significant other arterial disease. If you take one of these arginine 258 patients, here's an example of a patient we follow here in Houston. The entire aorta has been repaired. All the great vessels off the arch have been repaired, as have some of the mesenteric vessels. So this can be a very aggressive disease and needs to be managed aggressively. And unlike vascular Ehlers-Danlos patients, these patients do fairly well with surgery. Now, if we turn to the smooth muscle genes, there's even a wider range of variation in the age of onset, with PRKG having the earliest onset of disease and half the patients having an event by age 40. Overall, this is the earliest onset gene that we have identified, not TGFBR2, but PRKG1, earliest onset overall. Here's ACTA2, and then there's late onset with myosin light chain kinase. And once again, with ACTA2, we can start taking the individual variants and looking at the age of onset. So here's a variant with very early onset, arginine 179, and a variant that has very late onset and decreased penetrance, is glycine 160. And you can see there's not a real burden of early onset disease except for arginine 179, but many of the variants in the late teen years, early adulthood, can start causing events. So we want to move forward to start using these data to, like I said, do precision management. I just want to mention one interesting fact to me as a researcher, that if you take two genes, TGFBR1 and 2, and these make two proteins that come together and interact to drive TGF-beta signaling, if you look at gender, there's marked gender difference with TGFBR1, with the males having earlier onset disease than the females, but no significant gender differences with TGFBR2. And it's absolutely fascinating, especially given the fact we know that this disease in the general population affects more men than women. And so this might be a model to begin to understand that. And then I just want to give you an example of how dramatic this data can, how dramatically it can change the way we manage a patient with a variant in the gene. And this is a family where the mother does not carry the variant and her daughter does. The mother has already lost her husband and two sons to dissection. And one of the sons dissected at the age of 19, I'm sorry, at the age of 18. He was being followed for, because he carried the variant, because his father and brother had died of dissections under the age of 30 before the gene was identified. And so we were following him. He had a normal aorta. We had him on beta blockers. He got switched to losartan, and 3 months later, he died of dissection, and at the age of 18. So the younger daughter carried the variant. And we know from our studies that there can be little to no enlargement of the aorta when these patients dissect, just like we saw in her brother. She had mild dilatation, about 4.0. And then we just made the decision to go in and in consultation with the patient and her mother to go ahead and repair her aorta, because we know this is what the dissection curve looks like versus aneurysm repair for PRKG1. And this is the exact opposite of what you want to see. You want to see that if you do aneurysm repair later, you're preventing dissections. And this is the reverse. We're seeing early dissections with late aneurysm repair, and very early, a significant step up in the late teens. So went in and repaired her aorta, and she's doing well, and is now 2 to 3 years out. And I want to say that this data can define the aortic diameter for surgical repair. And some of the MAC data is in the AHA, ACC treatment guidelines that just were updated. Alan Berryman will talk about this later. We've also want to use MAC data to look and see in those low-STEAT patients with TGF-beta gene mutations, where do the other arterial events occur, and is there gender differences, and what are those other arterial events? So here's looking at a panel where arterial events in different arteries associated with different genes, and the specific events are listed. And our numbers are still low to look at this because the penetrance of other arterial events seems to be under 50% for all TGF-beta genes. But you can see that dissections are the major event that they have, and by and large, they're not going to surgery for dissections, but instead treated conservatively. You can see right away, just looking at TGFBR2, these events are more common in women than men, and if we look at the whole group, that's statistically significant, but for the individual genes, we just don't have the number yet. And one thing that came out of this is that it's smoking is really increases your risk for other arterial events. But we have a way to go with this data to really be certain, like, do we have to image for TGFB2? Do we have to image head to pelvis, which is recommended now, or can we decrease that imaging? And then we've been working on ACTA2 mutations to really define why they cause TAD, but also why they cause moyamoya and CAD. And I don't really have time to go through the details, but moyamoya disease, we understand the molecular pathogenesis so well that we're just got FDA and our local human subject approval to start a clinical trial to prevent moyamoya disease in patients with ACTA2. And we have a paper coming out this month in the European Heart Journal that explains how a mutant actin filament causes CAD. And just to go through the pathway briefly, it's only the mutations that are misfolded that activates HSF1 and cellular stress that cause atherosclerosis. They do this by increasing the amount of cholesterol that smooth muscle cells are making. And that leads to activates an unfolded protein response and ER stress that drives modulation and migration of smooth muscle cells and contributes to atherosclerosis. Completely new and novel pathway to atherosclerosis. And because it involves HMG-CoA reductase, can be prevented using statins. So we're going to move into trials to start statins early. We should be able to use a calcium score to look, because not all patients even with variants that cause atherosclerosis go on to develop atherosclerosis, and it probably is related back to how much the cell stress is generated with the misfolding of the protein. So we want to see if we can use calcium scores to figure out when to start, when the atherosclerosis starts in these patients, so we know when to start the statins and potentially who to start them in. So where are we going? We want to start looking at AI and facial patterns to identify mutation carriers in the general population and predict vascular disease risk. And we've been beginning to work with some experts in AI to define, starting with those TGF-beta gene mutations, where all of us that see these patients know that a TGF-br2 patient does not look like a SMAD3 and does not look like a TGF-2 patient. And we can begin to actually to identify facial gestalts with each gene. And further studies, we really need to address the naming of these disorders. Like I said, we can't be bunching LDS together. I don't even have time to talk about the systemic features and how much difference there is from gene to gene. We really want to use MAC for clinical trials going forward. We still have a lot of genes where we have to define the phenotype. We want to define treatment guidelines for early onset disease like neonatal Marfan syndrome and early onset disease with TGF-beta, TGF-br1 and 2 mutations. And we need a lot more details about the additional vascular disease so we can define surveillance and better treatments for the disease and start the treatment trials for moyamoya and atherosclerosis.